Good afternoon, everyone. Firstly, thank you, organizers, for giving me the opportunity. First time I'm talking in the lung cancer conference, though I'm a man of breast cancer, but let's see how I justify the today's talk. So just for the resident here, this is the 2020 data of the lung cancer, and every second the disease is increasing in the country. So far, so the way the therapies are improving in coming times, certainly we are going to get a lot of many such situations wherein the TKI, the IO and the chemo combination has been given, and subsequently patient lands in your OPD or in your hospital, how to manage them. So this is the topic given by none the less our the star player, Dr. Vijay Patel. I am in depth. Very much thank you for him for this topic. As you know, सब कुछ दे दिया, अब क्या करेगा? So एक फौजी को थमा दो, and the फौजी is also lost. This is the caption from the photo from the Second World War. And this is not the only man who gave this topic to me. There is another person, and whose name is also Dr. Vijay. And I believe that God has gifted him two brains and not just one. So this is just a simple question to all the resident or the the clinicians here. What is the best treatment available for your patient once he has received the chemo and the IO in the first line? So answer is pretty simple here. Anyone? So it's a kind of all of the above, all the options are there. And this is the reference or the literature. I got it from the Cancer Network. It is the Clinical Quadrantries series and very beautifully written by multiple authors across the world. I have added two more answers to this question, whether we can re-challenge with the chemotherapy or we can re-challenge with the IO. So let's start and proceed. So while reviewing the literature, I just came out with the only couple of articles, and one of them is this is the largest series. Again, this is not the perfect one to answer today's question. This is the only study available as on that date with the sample size of more than 300 patients, but only the patients who have received the single agent IO, in them what has happened. So basically, only 35% of the patient they received any form of second line therapy, and in this study they showed that the patients who have received the doublet, they only did better. And as with the dictum and the philosophy of oncology, the ECOG PS2 was the only predictive factor for basically outcome for survival on multivariate analysis. Very catching in this study is the two things which I want to highlight here is, the first is whatever the trial data is there for the enormous benefits of the therapies, but such kind of OS these people have not found on ground. Obviously, for the reasons are very clear. The trial selects very particular patient, and in a day-to-day life, hardly any one of our patients who has 0 PS or PS of 1. Majority, generally, they are with the 2. We manage to make it 1 and treat them. Second thing from this largest study, which is one must see that the OS is limited in second line setting in spite of giving the doublet post IO. That is 7.5 months with the platinum doublet, which is 5.3 for the single agent chemotherapy, and 3.4 months with the other regimens. The message is clear. We don't have much of robust evidence post chemo IO how to treat. Classic examples of treatment are docetaxel, and if the patient has not received platinum therapy in the first line, obviously this, you have to choose here the platinum base. So when you're in clinic, how do you select the patients, which are the patients we are going to treat? So for obvious reasons in the therapeutic approach, this classification is very good, and we have to segregate the patient into two subsets, whether they are primary resistance along with the hyper-progressive disease or the acquired resistance. For the benefit of the resident, I have included some of the pathophysiological aspects. You just have to know that there are various different kind of mechanisms they play in both the therapeutic approaches. So JAK2 and the mutations in the some beta-2 microbes, they are more common in the acquired resistance group. So the first definition or the first approach or the group of the primary resistance and the hyper-progressive disease, again, in the literature, this definition is very vague. Park et al. Has done a meta-analysis on this definitions on these various studies on the hyper-progressive disease. So the rate of hyper-progressive disease, though we commonly see that, and in the clinic or the practice, we say it's less than 5%. But in this meta-analysis, what they said, they found is there is incidence can be ranging from 1% to 42%. So why this has happened? Because there's a lot of confusion about the definition about the hyperprogression among all the clinicians and all the trials. They have used various criterias. But for me or the various clinicians, what we see in the clinic when the hyperprogression needs to be defined, it is generally at the first the response assessment, maybe post 3 cycles or 2 cycles, or the patient is clinically deteriorating, or there is some new lesions you are finding. So for the reference, the Cato and the Ferrara et al., they have done a better work, and in their study, when they have said that the time to treatment failure less than 2 months, the frequency is around 8%, and we take it as a RECIST criteria, an increase in the tumor growth rate of more than 1.5 times if it is increasing, then it is the 14% rate in the hyperprogression. So what do you do? So these are the very classic the Kaplan-Meier's from the keynote trials. So this very the pictures can give you the very basic understanding of how the curves are separating. So where if you see the single agent pembrolizumab and the chemo, when it is compared with the chemotherapy, there is overlapping of the or the crossing of the curves are happening at around 6 or 8 weeks time. But these things are not happening in the pembrolizumab combination when it is compared with the chemotherapy doublet. So point the message is very clear from these two Kaplan-Meier that the hyperprogression might happen with the single agent pembrolizumab. And so when you are looking for the patients who are sick or disease burden high, so when you're opting for the therapy, such kind of Kaplan-Meier's or such kind of crossing of the curve should help you in making the decision that chemo-IO is always a better combination here. Then comes for the acquired resistance. Some of the patients who are coming to you after some time, or they are on the maintenance therapy of some sort, or after maybe 3 months or 6 months, or at the max 9 months of therapy, treatment-free interval, they are coming with the disease, and you define these patients as acquired resistance. So very simple again, when you are managing these cases, one has to see what is the progression type. So whether it is oligoprogression or it is a multimetastatic progression. Point is very simple. By and large, we see the biology of the disease is like that. So the oligometastatic from the beginning in the oncology, especially after the era of TKIs and the immunotherapy, we are treating them in separately. We don't take the oligometastatic as just an end of the therapy. So what do we do here? We treat the sites with the either radiation and continue the whatever the immunotherapy or the chemotherapy is going on. But same thing is not for the multimetastatic disease. Come to the point of the second line options. As I said, it is kind of a vintage therapy, and mind it, vintage word is not that bad word. And I was looking for the literal meaning for the vintage. See what beautiful word that means. You know, there is timeless, superior, best, classic, old. So don't worry on that aspect that the vintage is nothing is there. So let's see what are the options here. I hope you got the message. So every 20 to 30 years, the truth is always changed. So long back, Professor Govind Babu must be acknowledging that 20 years back, even paclitaxel was giving them the, happiness, and such conferences were organized because of the nab-paclitaxel and paclitaxel. So point is here to tell you that there are always options. We know that in the second line setting, we don't have any phase 3 data because the majority of the patients, they are not going to come in a good performance status. So in the literature, there is not even single phase 3 trial comparing the therapies in the second line setting. Whatever the data we have, they are all based on phase 2. We all know what is the best therapy available in the second line setting. It is the docetaxel, and docetaxel at 75 milligram per meter square every 3 weeks, and generally we give 6 cycles. So with the vintage, this is the article from the 2000, wherein the best supportive care was compared for the docetaxel in the second line. This is the only drug which has been studied in the phase 3 design. That's why this standard of care is, or we are taking that as the most effective drug in the second line setting. So there is another trial by from America, wherein the docetaxel was compared with the best supportive care, and the other trial which I just mentioned is the docetaxel was studied. This is a 3-arm trial in which 75 milligram per meter square, 100 milligram per meter square, and it was compared with vinorelbine and ifosfamide combination. Believe me, the vinorelbine ifosfamide had less than 1% of response rate, and docetaxel had around 7 to 8% of the response, and the response were higher in 100 milligram, but there were issues with the tolerance. But somehow the overall survival benefit of around 2 months was seen with the docetaxel 75 milligram per meter square, and that's how it became the standard of care in this setting. Also in the other trial, when they have changed the algorithm on the basis of when the patients couldn't tolerate the 100 milligram dose, the trial was changed in between to 75. And in that also, when it was compared with the best supportive care, there was significant overall survival benefit. These are the other second line chemotherapy for the recurrent stage 2 or the stage 4 lung cancer. So these are the various drugs which have been studied, and the response rates range from 0 to 14%. So there is another trial in the second line setting. Obviously, here there is the pertaining to our question of immunotherapy and the chemotherapy combination. In this trial, those were not the patients included, but somehow we don't have much to offer these patients, and this study should be sometime helpful to all of us. Though the margin of benefit is just 1.4 months in terms of overall survival, certainly when the ramucirumab was launched, I was not very keen for this drug to use. But when you see all the subgroup, including the commerce histology, non-commerce, or the rapid progressors versus non-rapid progressors, so the maximum benefit is around 2 to 3 months for the patients who also have the rapid progression. So the combination of ramucirumab with the docetaxel may be another option for such patients. So certainly we don't have till date data for ramucirumab post IO chemo combination. This is the Kaplan-Meier for the REVEAL trial. I will just finish in next 2 to 3 minutes. What about the re-challenge? So this re-challenge concept is very well established in small cell lung cancer, as we all know. After 6 months, or some people might offer it after 3 months when the patient is coming back again, and we generally offer the same regimen. Can this be same thing offered in non-small cell lung cancer? So the data is not that robust. We have re-challenge chemotherapy, the trial from the Japan. And here in what they have shown is that if you re-challenge the chemotherapy for the patients who have disease progressed more than 5 months after the initial regimen, and if you are going the same initial regimen, then certainly and they do well with the docetaxel. But again, the problem is these trials are very old, and if you see, the first line chemotherapy options were very, very different from the what we use in today's world. So how I treat? When the patient comes to you, how are you going to treat such kind of a patients who are coming to you after IO and the chemo progression? So we see what is the time of the progression. At first assessment, obviously, we don't have much to offer. You can give the docetaxel plus anti-angiogenic agent. And if you have some trial at your institute, certainly you should think about enrolling such patients to the clinical trial. And as I already mentioned about the acquired resistance, when the patients are coming to you, if there's a oligometastatic disease, you can just give more local therapy and maintain the treatment. And if it is multiple site, again, as per the primary resistance, you can treat this patient. Same thing from the UpToDate and from the cancer network, and obviously in the NCCN also, there is nothing much talked about. So in some of the intriguing questions, as a lot of I see here, the audience is from the trainee field. You must see what is there in the literature. So there are always intriguing questions. How do you challenge this situation of, for the sequencing? We all know that everything works better or the best in the first line setting, but always in the literature, there are some studies which you can give some sort of new thought to it. And this is what I got while reviewing the literature. So there's a sequencing of the therapy, what will happen. So this OS or PFS doesn't make a difference. But when you use the immunotherapy subsequent to the chemotherapy, our overall response rates are better. So these such kind of questions are always addressed somewhere in the literature. This is a phase 3 INSIGNA trial, which is enrolling the patients, and all those questions which come to your mind, when can we better rationalize the use of resources, whether you should in the beginning or subsequently, this trial is going to answer this question. Last but the least, before the thank you slide, it is what about the re-challenge with the immunotherapy? So when you're thinking about the re-challenging, and sometimes some or the other odd cases might come to you, but when you're thinking about such thing, we must know in the absence of any data or case report or any kind of a series, we should go by what is there in the PK/PD. So this is the washout time, and this is the half-life of these immunotherapy drugs. One must take into consideration they remain in the blood for a longer time. The T lymphocyte, the responses are there. They are maintained for many months post immunotherapy. Just for the Kshitij is around, so I don't agree to him fully on the concept of performance status. These are the two areas. One is editorial, and the other is the article in the JCO. One must read how you must use the immunotherapy in special cancer patient populations. Here, there is a nice rebuttal given by the Raja, and wherein they have shown that this article, whatever mentions that autoimmune disease, poor performance status, comorbidities, everywhere you can use the immunotherapy, but performance status is not the same as the autoimmune disease. In the poor performance status patients, whatever the article has quoted, they were all the patients from the specific category, and that is MSI high patients. So whenever you are thinking about using in the first line, there is anecdotal with everybody's experience that in the clinic, when we are looking at the patients, when you use the immunotherapy in poor performance status, generally they don't do well, but we always remember those patients who do well. So be cautious about it. And as for those initial Kaplan-Meier I have shown you, a single agent immunotherapy might be sometimes detrimental because of the hyperprogression. Just for the amusement or some kind of, for the resident, sometimes I keep some slide. Can you tell me any very rare, unique toxicity of the docetaxel? As docetaxel is the only kind of hero here in today's presentation. I will conclude with this. So excessive tearing. I hope with this you got benefited with the whatever the slide. Any questions? 1 or 2 questions we can take. Thank you.